Thanks for showing up at the early industry sessions. I'm Brett Crist, and we're going to go over CurvaFix, and the faculty for this is Julie Schweitzer, Daniel Bravin, and Chip Rout is joining us remotely. And so this is the agenda for the morning. I'm going to go over the technical details of the implant and some early data that we have. And then we'll hear from Dr. Rout and Dr. Bravin on some cases. And then Dr. Schweitzer is going to talk about kind of just especially geriatric fractures in general and how the system is failing us, at least in the United States. And I don't think we're that abnormal from other countries. It's good to see familiar faces. Yeah. All right, so CurvaFix allows you to fill curved corridors and provide strong fixation. So it's I would say one of the few implants that's actually adaptive to the individual patient's anatomy and allows for safe passage. It does allow for early weight bearing, and I actually haven't had any of them back out. It's been kind of an interesting journey in using it. Because I have personally noticed a difference. So the adaptive design, somebody mentioned we had a kind of information meeting last night about some research that we're doing. And one of the things that we don't want to miss is kind of having everybody understand the design of it and how it makes it a rigid implant after you get it in. And so basically there's a 7.5 and 9.5 millimeter diameter option. The interlocking components, as you can see, is from basically how the metallic components are, and then the internal compression device that you can see partially here, and I'll show you some other parts of it that make it a rigid implant once you get it in. But there's a self-tapping design for the threads and the front cutting end, and then it's a stainless steel device. And there have been some removals, and including a couple of broken ones, but the removal process hasn't been a significant problem. I've taken one out, and the cables kind of stayed together to get it out. But this is how it becomes a rigid implant. So there's 4 cables that are similar length, and then when you become in the rigid state, when you lock it, the cables provide compression. And one of the things that you have to get used to is actually the implant will get some compression in that fashion. So it will shorten up some as you compress it to lock it. But this is just a diagram showing some of the, flexibility in the design. And that's one of the things that kind of made me think about using it is getting around implants that are indwelling already, especially in the sacrum. But it allows you to have a little bit more freedom for your starting point as well. So compared to straight versus curved implants, obviously if you're using a straight rigid implant, you're not as flexible or have as many options as something that curves and follows the corridor basically. And so there has been some biomechanical data that shows that the pullout strength is significantly higher than both 6.5 and 7.3 millimeter cannulated screws. And you could see, 715 newtons versus the closest one is 503. So just some updates and some kind of background. So it was designed by Dr. Meek, who's actually here, if you want to talk to him afterwards, to get his thoughts and why he thought it was important to kind of bring this to fruition. It's been in use since 2019. There's over 125 surgeons using it currently, and I'm sure that's going to add as the time goes on for sure. It's used in over 85 facilities. And we are kind of looking at trying to get safety and efficacy data, especially in geriatric pelvic fractures. And so if you have any interest, if you start using the implant and want to contribute to both a prospective and there's a retrospective arm of the study as well, please contact me. Obviously, you can get me through the OTA or just come up to me afterwards. So to date, the implant breakage is 0.3%, 1.3% for removal and revision, loss of fixation 0.3%, removal or revision due to loss of fixation 0.3%. So all of these are very low. Longest time to implant removal is 2 years. So that's a pretty long time. It's not like you're taking these out at a year if you're going to take them out or at least that's what's been done. And typically in geriatric patients, I don't take them out, I just leave them in. So this is the implant removal at 2 years due to sacroiliac pain, and this is kind of the indication where I would take it out is if I'm using it in somebody young. I take at least have a conversation in all the patients that are under 65 that have iliosacral screws, at least talk to them about taking the implants out because I think it does increase the stress on the lumbar spine. But they got it out at 2 years after surgery, and it was removed in less than 20 minutes. And with each kind of iteration, the removal tools are getting easier to use as well. So over 500 patients have 1 year post-op follow-up. This is time from surgery just to overall, as you can see. Most of them are less than 12 months or 1 to 2 years. There's a few, 3% at 3 to 4 year. Utilization in the elderly and fragile bone patients or osteoporotic patients is increasing, which oncology is included in that. This is the implant locations, so 50% in the ilium and sacrum, pubic or anterior pelvis, 35%. The LC2 corridor is 5%, and the acetabulum is around 10%. And we'll see some of those cases today. It is kind of mostly used in nonlinear pathways, and most pelvic corridors can accommodate the 7.5 or 9.5. My personal use, I've used the 7.5 mostly in the front of the pelvis, which makes sense. It's a smaller corridor than most posterior corridors. But these are some case examples of different pathways that are curved and or nonlinear. I think it's also very helpful in people with sacral dysmorphism or abnormal kind of baseline anatomy. But here's some early data that's actually at the new techniques and emerging evidence section here, that 3 of us combined data from 3 centers. And you can please take a look at the poster for more specific details. But we had 111 patients at 3 centers, 90 or over 80% were made weight bearing as tolerated. Which the goal is to do that, especially in geriatric patients where weight bearing them is tolerated right away. Over around 50% were unassisted at most recent follow-up for ambulation, less than 10% complication rate. There were 2 malpositioned implants, 1 broken implant, and 1 bladder injury. And then postoperatively, 2 nerve palsies, 1 wound breakdown, and 2 infection. And besides the implant that broke, no loss of hardware failure, loss of reduction.